Hello, everyone, and welcome to our module on heart murmurs. So, heart murmurs are cardiac sounds. They're sounds created by the movement of blood through the heart, and they're identified by using the stethoscope to examine a person's heart. And the cause of heart murmurs is turbulent blood flow, and I'll explain what I mean by this in just a minute. And you should know that heart murmurs can be due to the normal functioning of the heart and the normal blood flow through the heart, or they can be pathologic and indicate some type of underlying heart condition. So let's explain what we mean when we say that murmurs are caused by turbulent flow of blood. So there are two ways that fluid flows through a structure like the heart or a blood vessel. One is called laminar flow, the other is called turbulent flow. In laminar flow, fluid moves through a structure like this blood vessel shown here in layers. That's what the word laminar means, layers. And you have some blood moving at this speed right here along the wall. That might be slower because it's dragging against the wall. You have other blood flow moving in a layer like this. That blood might be moving slightly faster because there's less resistance from the wall. But nevertheless, what you have are these layers of moving fluid through the vessel. And in general, laminar flow is quieter blood flow. It generates less sound. Now, you might think that if you sped up the blood flow, the layers would just all start moving faster, but that's not what happens. When you cross a certain threshold, the blood flow starts to form these little swirls and eddies, and this is called turbulent flow, and it makes lots of noise. It's much louder. And so things that cause turbulent flow are, first of all, high flow rates, in other words, high velocity of fluid moving through a structure like the heart, and also narrow flow areas. If the area for flow is very narrow, that's more likely to generate turbulent blood flow. There's a long-standing system that's used to grade the intensity or the loudness of a murmur, and it ranges from 1 to 6, like what's shown on the slide here. So grade 1 murmurs are barely audible. Grade 2 murmurs are faint but easily audible. Many murmurs we hear in clinical practice are grade 2. Grade 3 murmurs are loud and easily audible, but there is no thrill. A thrill is a vibration you can feel with your hand against the patient's chest. That's caused when there's lots and lots of turbulent flow. Then grade 4 murmurs are louder and they have a thrill. Grade 5 murmurs can be heard with the stethoscope barely touching the chest. And finally, grade 6, which are the loudest murmurs, are audible with the scope not touching the chest at all. Besides the grade of the murmur, there are some other important descriptors we use in clinical practice. And one of the biggest is whether the murmur occurs in systole or diastole. This gives you a big clue about what might be causing the murmur. So recall that systole is the time between the two heart sounds, S1 and S2. There's then a relatively longer pause, that's diastole, and then you get the next S1 and S2. So one of the most important descriptors of murmurs is whether they are systolic or diastolic. Another important descriptor is the way the intensity or loudness of the murmur changes over time. A murmur that is holosystolic or pansystolic is a systolic murmur with the same intensity throughout systole. In contrast, a crescendo murmur is a murmur that gets louder over time, and a decrescendo murmur is a murmur that gets quieter over time during the cardiac cycle. And then, as we'll talk about later in this video, many murmurs are what's called crescendo-decrescendo. This means that the loudness or intensity of the murmur gets louder until it reaches a peak, and then it falls down to a quieter level. Another important descriptor of murmurs is the location on the patient's chest where the murmur is heard best or loudest. And that information is shown on this slide, and this is super high yield for the Step 1 exam because they're going to describe to you the locations on the chest where the murmur is heard loudest, and that's going to be an important clue as to what's causing the murmur. So let's start with this point labeled A, which is sometimes called the aortic projection area. This is the second intercostal space at the right upper sternal border here, and this is where you hear the murmur of aortic stenosis the best. And aortic stenosis is a very common murmur that you will hear in clinical practice. On the left side of the chest, the second intercostal space at the left upper sternal border, this is where you hear pulmonic murmurs, like flow murmurs of blood moving past the pulmonic valve, or pulmonic stenosis or regurgitation. It's also where you can hear the murmur of a patent ductus arteriosus in a baby the loudest. If you go one interspace down to the third intercostal space at the left sternal border, this is a position called Erb's point, and that's where you hear aortic regurgitation the loudest. Aortic regurgitation is usually heard loudest in a different location than aortic stenosis. Make sure you keep that straight. And then Erb's point is also where you hear the murmur of hypertrophic cardiomyopathy the loudest. Down here we have the fifth intercostal space at the left lower sternal border, And this is where you hear murmurs from tricuspid valve disorders loudest, and also murmurs of a ventricular septal defect. And then finally, if you go to the fifth intercostal space and you move out to what's called the mid-clavicular line, meaning the line in the middle of the clavicle up here at the top, that's the mitral projection area. That's where you hear mitral murmurs the loudest. This is also the apex or point of the left ventricle. You can feel this with your hand. And in a normal patient with a normal heart, that's usually also felt at the mitral projection area, meaning the fifth intercostal space at the mid-clavicular line. Associated with murmurs, there are some other cardiac findings that can be important clues as to what's going on in the patient's heart. One is the location of the point of maximal impulse, also called the apical impulse. So if you place your finger in the fifth intercostal space on the patient's chest and you move it out to the mid-clavicular line, like we talked about in the last slide, you should feel the pulsation of the left ventricle as it contracts. And this location is called the point of maximal impulse or the apical impulse. Now, normally that's in the fifth intercostal space in the mid-clavicular line. But if they tell you in a board question it's shifted left, meaning further out to the periphery of the patient's chest, they're telling you the patient has an enlarged left ventricle or enlarged left heart. You can see that in patients who have hypertrophic cardiomyopathy with thickened walls of the left ventricle. You can also see it in patients who have dilated cardiomyopathy and a dilated left ventricle. Sometimes they will tell you that the point of maximal impulse is hyperdynamic. This means it's more vigorous and stronger than usual. And when they tell you this, they're trying to tell you that the patient has some reason for sympathetic nervous system stimulation. So you can see a hyperdynamic point of maximal impulse in patients who have sepsis or patients who have gone through trauma. It's not necessarily an underlying heart condition. It just means the heart is working extra hard. And then in rare cases, they'll tell you that the point of maximal impulse is felt in the epigastric or subxiphoid area. When they tell you this, they're trying to tell you that the patient has an enlarged right heart. And this is what you can see in cor pulmonale. I talk about cor pulmonale in other videos, but it's isolated right heart failure, usually occurring in someone with lung disease and pulmonary hypertension. And in those patients, the right heart gets large, but not the left heart, and they can have a point of maximal impulse felt best in the epigastric or subxiphoid area. So before we get into pathologic murmurs, let me mention innocent or functional murmurs. These are murmurs that are caused by normal flow of blood through the heart. They're very common in children and also in young, thin patients. In both of these groups, there's usually not a lot of chest wall tissue, and so you can hear the flow of normal blood moving through the heart. These are generally soft murmurs, they're always systolic murmurs, and the patient should have no signs or symptoms of heart disease. So some examples of the terms used to describe innocent or functional murmurs are a Stills murmur, a pulmonic flow murmur, or a venous hum. These are all terms used to describe normal, innocent, functional murmurs heard in young, thin patients where it's easy to hear blood flowing through the heart. Okay, but now we're going to focus on pathologic murmurs, and the most important distinction between the different types of pathologic murmurs is whether they occur in systole or diastole. This is a huge clue to the underlying cause of the murmur. So systolic murmurs, as I said earlier, occur between S1 and S2. This is when the heart, the left and right ventricles, are contracting and squeezing. And so in systole, this is when you can hear the murmurs of aortic stenosis, mitral regurgitation, pulmonic stenosis, tricuspid regurgitation, also hypertrophic cardiomyopathy, and also the murmur from a VSD. And we'll talk about all these things later on in this video. In contrast, diastolic murmurs occur between S2 and the next S1. This is when the heart is relaxing and the ventricles are filling with blood. And this is when you hear these murmurs shown here, the murmurs of aortic regurgitation, mitral stenosis, pulmonic regurgitation, and tricuspid stenosis. And we'll also talk about all these conditions later in this video. Okay, so now let's go through the pathologic murmurs, and we'll start by talking about aortic stenosis. So aortic stenosis is a systolic murmur, and it's classically described as a crescendo-decrescendo murmur. And crescendo-decrescendo murmurs are also called ejection murmurs because when blood is ejected from one of the ventricles, it creates a murmur that rises in intensity as blood initially is shoved out of the ventricle and then falls in intensity as the blood flow diminishes. So to understand aortic stenosis, recall that we have blood in the left ventricle. It needs to leave the left ventricle and get into the aorta. And in order to do that, it has to cross over the aortic valve. This blood movement occurs in systole. So if there is aortic stenosis, it will create a systolic murmur. And then as blood tries to move through the very narrow aortic valve of aortic stenosis, that's going to create a narrow area for blood flow. And remember what I said before, that creates turbulence. and that's what causes the murmur of aortic stenosis. And so now I'll play you an example of the murmur of aortic stenosis. One thing to know about identifying murmurs based on how they sound is that this is very difficult to do. So they're rarely going to ask you to identify a heart murmur purely by the sound in a board question. They're going to give you lots of other clues, like whether it's systolic or diastolic or where it's heard best on the chest or patient characteristics to help you identify the cause. So listen carefully to the murmur, try to understand it, but if that's difficult for you, don't worry too much because board questions will give you other clues to identify the cause of the murmur. Okay, so here's the murmur of aortic stenosis. Try to listen for S1 and S2 and notice that the murmur occurs between those two sounds in systole. There are certain findings on physical exam that let you know whether or not aortic stenosis is severe, and these are high yield to know for your board exams. So one of the findings is when the murmur peaks. If it peaks late in systole, this means there's very slow flow across a very stiff and stenotic aortic valve, and this means the patient's aortic stenosis is more severe. So you have S1, and then you have S2, and then as we've discussed, the murmur is a crescendo-decrescendo murmur. Well, if this peak occurs later in systole, that's a late peaking murmur, and that's a sign of severe aortic stenosis as compared to mild or moderate disease. Another sign of severe disease is a soft or quiet S2. When the valve is very, very stiff, the leaflets can't slam shut, and that will make the second heart sound much quieter than normal, so that's another finding of severe disease. And then finally, a classic finding of severe aortic stenosis is called pulsus parvus e tardus. This means weak and small carotid pulses. It's also sometimes described as a delayed carotid upstroke. So if you place your hands on the neck of a patient with severe aortic stenosis, the carotid pulse will be slow and relatively weak, and that's what happens when there's severe aortic stenosis because it's hard for blood flow to move beyond that stiff aortic valve. The easiest way to appreciate this in actual practice is to find a patient who has severe aortic stenosis, feel the carotid pulse on their neck, and feel your own, and you'll notice the difference between your own, which should be forceful and strong, and the aortic stenosis patient, which will be weak and small. In another video, I talk about hypertrophic cardiomyopathy in detail, but you should be aware that this heart condition can create the exact same murmur as aortic stenosis. It will be a systolic murmur that is crescendo-decrescendo. The only way to tell aortic stenosis from hypertrophic cardiomyopathy using your stethoscope is to ask the patient to perform certain maneuvers. The most important maneuver for differentiating aortic stenosis from hypertrophic cardiomyopathy is the Valsalva maneuver. This is where you ask the patient to bear down like they're having a bowel movement. This will decrease the venous return to the left heart and the preload in the left ventricle. When you do this, the murmur of hypertrophic cardiomyopathy will get louder, and the murmur of aortic stenosis will get quieter. And so this is the most important way to distinguish these two conditions. And I talk about this in much greater detail in the video on hypertrophic cardiomyopathy. Okay, let's stick with the aortic valve and now talk about aortic regurgitation. This is a diastolic murmur, and it's classically described as a decrescendo blowing diastolic murmur. Decrescendo meaning the loudness or intensity decreases over time, and it's described as blowing because it has a sound like blowing air. So remember, it's going to occur after S2, before the next S1, that's diastole. And I'll play an example of this now for you to hear. Okay, now let's move on and talk about the mitral valve, and we'll start with mitral regurgitation. So mitral regurgitation is a classic cause of a holosystolic murmur, and it's heard best at the apex of the left ventricle, which we talked about earlier. That's the fifth intercostal space at the mid-clavicular line. And it's a holosystolic or pansystolic murmur, meaning it's a murmur that occurs in systole between S1 and S2, and the intensity does not increase or decrease over time. And I'll play you an example of the murmur of mitral regurgitation now for you. Okay, now let's talk about mitral stenosis. So mitral stenosis is a diastolic murmur, usually described as rumbling. Remember that blood has to go from the left atrium into the left ventricle, cross the mitral valve. And so if the mitral valve is stiff and thick, then when blood moves from the left atrium to the left ventricle, that's going to cause turbulent flow. And this flow from the left atrium to the left ventricle occurs in diastole, and that's why mitral stenosis is a diastolic murmur. It's classically preceded by a sound called an opening snap in diastole. This is created when the stiff mitral valve leaflets open to allow blood to flow from the left atrium into the left ventricle. So classically, the way you hear the murmur is it will occur after S2, so that's in diastole. You'll first hear a sound just after S2 called an opening snap, and then you'll hear the diastolic rumbling murmur that occurs just before the next S1. Differentiating this opening snap from other heart sounds that occur after S2, like S3s and S4s and split S2s, is extremely difficult in clinical practice. It's not something you need to worry about for step 1. But you should know that there is going to be a sound after S2 called an opening snap in patients that have mitral stenosis. So I'll play you an example of this murmur for you now. See if you can appreciate the opening snap after S2 and the diastolic rumbling murmur. Some other special things to know about mitral stenosis. You cannot get a left-sided S3 or S4 in mitral stenosis. In the video on heart sounds, I talk about the S3 and S4 sounds. They're generated when blood moves quickly from the left atrium into the left ventricle during diastole. Well, when you have a stiff mitral valve obstructing that blood flow in diastole, the blood fills the left ventricle much more slowly, and that doesn't allow the creation of an S3 or S4 sound. So you don't get those classically in patients with mitral stenosis. You should also know that the time to the opening snap is associated with disease severity in mitral stenosis. Let me explain what I mean by this. So remember that we have the first heart sound, then we have the second heart sound, and then we have the opening snap, followed by the diastolic rumbling murmur. This time between the second heart sound and the opening snap is called the time to opening snap. And the shorter that time, the more severe the mitral stenosis. The reason this happens is because when you have a stiff mitral valve, it's hard for blood to move from the left atrium into the left ventricle, and blood will back up into the left atrium and cause high left atrial pressure. That high left atrial pressure will push the mitral valve open more quickly and decrease the time to the opening snap. So basically, when you have very high left atrial pressure, the time between S2 and the opening snap gets smaller. And so a short time to the opening snap is seen in severe mitral stenosis where the left atrial pressure has gotten very high. And it's high yield to know this for your board exams. The murmurs that you can get on the left side of the heart from aortic stenosis or regurgitation and mitral stenosis or regurgitation, you can also get on the right side of the heart from tricuspid or pulmonic valve disease. In general, the valve lesions create murmurs that sound just like their left-sided counterparts. So tricuspid regurgitation sounds like mitral regurgitation, and pulmonic stenosis sounds like aortic stenosis. The main distinction is the locations where they're heard. Remember that the left upper sternal border is where you hear pulmonic sounds like pulmonic stenosis and regurgitation, and the left lower sternal border is where you hear tricuspid sounds like stenosis and regurgitation. So in a board question, one of the ways you're going to know that they're talking about right-sided lesions like tricuspid and pulmonic disease and not left-sided lesions is by the location where the murmur's heard best. Another way you can distinguish right-sided from left-sided heart murmurs is by looking for something called Carvalho sign. So Carvalho sign is based on the principle that most right-sided heart murmurs, like those associated with pulmonic or tricuspid valve disease, become louder when the patient inspires compared to when they exhale. So if you listen to the heart murmur as the patient breathes normally, if you identify that it's louder with inspiration, that suggests it's a right-sided murmur caused by tricuspid or pulmonic valve disease. The reason this happens is because when patients inspire, they draw blood volume into the lungs, and this creates more blood flow through the right side of the heart, and that generally makes right-sided heart murmurs louder. So if you're listening to the patient during normal, quiet breathing, you will hear right-sided murmurs get louder, and if the patient has a left-sided murmur, it will get softer. And if you want a simple mnemonic to remember this, just remember right-sided murmurs, the I here is for increase with inspiration. Left-sided murmurs, the E here is for increase with exhalation. Now let's talk about the murmur that occurs in patients who have a ventricular septal defect. I talk about VSDs in detail in videos in the embryology section, but by way of review, in a VSD, there's a hole in the wall between the left and right ventricles, and when blood moves through that hole, that causes a murmur. So the murmur that occurs when there's a VSD is a holosystolic murmur. It sounds just like the murmur of mitral regurgitation. And one thing to be aware of is that when the VSD is very small, that makes more turbulent blood flow. Like we talked about before, turbulence depends on the size of the area where blood is flowing through. So small VSDs, which are often asymptomatic, can be associated with a very loud murmur. In contrast, patients who have a large VSD sometimes have a quiet murmur or no murmur at all. And so once again, the murmur of a VSD is a holosystolic or pansystolic murmur. It occurs between S1 and S2. And I've always found it helpful to remember that in terms of holosystolic murmurs, there are really only three important causes. I've shown them all on this slide. They are mitral regurgitation, tricuspid regurgitation, and a VSD. Patent ductus arteriosus, or PDA, is another congenital heart condition that I talk about in videos in the embryology section. But in a PDA, there's a connection between the pulmonary artery and the aorta. And so blood will flow through this connection in systole and diastole. Therefore, the murmur that you get is continuous, meaning it occurs throughout the cardiac cycle in both systole and diastole, and it's classically described as a machine-like murmur that goes from S1 to S2 to the next S1 to the next S2. It's continuous throughout all phases of the cardiac cycle. And I'll play you an example of what this can sound like now. Hopefully you're able to appreciate that the sound is continuous. It doesn't start and stop with one phase of the cardiac cycle. Okay, I'll finish this video by talking about maneuvers. So maneuvers are performed at the bedside with a patient, and the idea is to see if particular murmurs increase or decrease the loudness or intensity of the murmur. And this can be helpful to make a diagnosis. Certain murmurs get louder with certain maneuvers, and other murmurs get quieter with certain maneuvers. Most of the maneuvers that we use at the bedside do one of two things. Either they increase the preload to the left ventricle and the venous return to the heart, or they decrease the preload and the venous return. When you increase the preload, more blood moves through the left side of the heart, and this will make certain murmurs louder or quieter. When you decrease the preload, less blood moves through the left side of the heart, and this will also make certain murmurs louder or quieter. The two maneuvers we use to increase preload are raising the legs and squatting. So this is a picture of what leg raising looks like here. When you raise the legs like this, blood is going to fall back towards the heart, and you're going to get more venous return and more preload. You can accomplish the same thing of raising the preload by asking the patient to squat. When they do this, blood that is in the legs is forced back toward the heart. Basically, you compress structures in the legs and you push blood up towards the heart, and this will increase the preload. The two maneuvers for decreasing preload are the Valsalva maneuver and standing. I'll talk more about the Valsalva maneuver in just a minute, but what happens when patients Valsalva is they raise the pressure in the rib cage, in the thorax, and this compresses veins, and it makes it harder for blood to flow into the venous system and back to the heart, so it lowers the venous return. Same thing happens when patients stand. Blood falls towards the feet, away from the heart, and this reduces preload. It's basically the opposite of the leg raise technique. And as we'll talk about in a little bit, most murmurs increase with more preload. There are just two exceptions. One is the murmur of hypertrophic cardiomyopathy, and the second is the murmur of mitral valve prolapse. And I talk about hypertrophic cardiomyopathy in its own video, and I talk in detail about mitral valve prolapse in the video on heart sounds. So let's talk briefly about the Valsalva maneuver. There are a number of ways to ask patients to do this, but one of the most common is to ask the patient to bear down as if they're trying to move their bowels. When they do this, this initiates the Valsalva maneuver. The first few seconds is called phase 1. During this time, the thoracic pressure goes up. From bearing down, there's more pressure inside the thorax, inside the rib cage. As I told you on the last slide, this is going to decrease venous return. You're compressing veins inside the thorax. This is going to raise the pressure in the venous system and in the right atrium, and that's going to make it harder for blood to flow. Because remember, blood in the body is flowing into the right atrium all the time. If you raise the right atrial pressure, there's less driving force to move blood back to the right atrium. So that's going to decrease the venous return. And that's what happens in the first phase of the Valsalva maneuver when patients bear down. Now, also in the first phase, there's a transient rise in aortic pressure. This is from compressing arteries, and this slightly raises the blood pressure. And in response to this, the baroreceptors are activated in the body, and they tell the brain, which activates the sympathetic nervous system and the parasympathetic system, and you get a fall in heart rate and AV node conduction. So the main things that happen initially in the first phase of the Valsalva maneuver are a fall in venous return and a decrease in heart rate. But after a few seconds, phase 2 begins, and phase 2 is dominated by the fall in preload from the decrease in venous return. This is going to reduce the cardiac output. And when this happens, the brain will activate the sympathetic nervous system and increase the heart rate and increased AV node conduction, all through sensing blood pressure changes and cardiac output changes through baroreceptors. But in terms of heart murmurs, what you want to know is that when patients Valsalva, preload is going to go down, and that's what's going to affect most of the murmurs that you're listening to. And then finally, there are two maneuvers that affect afterload. These are not done very commonly in the modern era. One of them is to ask the patients to clench their fist. This is the hand grip maneuver. This will slightly increase the afterload. And then to decrease the afterload, there's a vasodilator called amyl nitrate. It's very short acting. And this isn't really done much anymore, but it used to sometimes be administered to lower the blood pressure and lower the afterload and see what effect that had on the heart murmur. So I told you before that when you increase the preload through a maneuver, that generally makes all murmurs louder other than hypertrophic cardiomyopathy and mitral valve prolapse. Now let's talk about what happens when you change afterload on the left ventricle. So if you have a backward valve disorder, this is where blood is moving in a backwards direction, like in aortic regurgitation, blood is moving backwards across the aortic valve, or mitral regurgitation, where blood is moving backwards across the mitral valve, or a VSD, where blood is moving backwards from the left ventricle to the right ventricle. In all these so-called backward disorders, when you raise the afterload, the murmur gets louder. And that's because with more afterload, there's more force pushing blood backward, causing these murmurs to occur. On the other hand, if you have a forward valve disorder caused by the forward movement of blood flow, things are different. So examples of forward valve disorders are mitral stenosis, where blood is moving forward across the mitral valve from the left atrium to the left ventricle, or aortic stenosis, where blood is moving forward from the left ventricle to the aorta. In these so-called forward valve disorders, the murmur gets softer with more afterload. That's because there's less pressure difference moving blood forward. Basically, you have more afterload, it's resisting the forward flow of blood, and therefore there's less movement of blood and the murmur gets quieter. And then just like with preload, there are exceptions to these rules, which are mitral valve prolapse and hypertrophic cardiomyopathy. Both of these get softer with more afterload, and that's because afterload increases the size of the left ventricular cavity. And once again, I talk in detail about both of these conditions in other videos. So I'll finish with this summary slide of commonly tested murmurs and when they occur. Remember, it's very high yield to know whether the murmurs occur in systole or diastole. And then it's also important to know the different characteristics as far as whether they're pansystolic or crescendo, decrescendo, or continuous. And then lastly, let me finish with this one slide showing Wigger's diagram, which I talk about in detail in another video. So Wigger's diagram shows events that occur throughout the cardiac cycle. And between S1 and S2 is where systole occurs, and from S2 to the next S1 is diastole. And so we've been talking about how these murmurs occur in either systole or diastole. But you should be aware for your board exams that they also occur related to other events in the cardiac cycle. So they could tell you, for example, that a murmur occurs just after the QRS complex on the EKG, and you should know that that means it's a systolic murmur. They could also tell you that a murmur occurs just after the aortic valve opens, which is right here, and they would be telling you that that's a systolic murmur. So make sure you can identify systole and diastole among all the events that are occurring on Wigger's diagram, because that may be able to help you out when you're answering questions about heart murmurs. And that concludes our module on heart murmurs.